Good afternoon, Sawadee Khab. On behalf of Medtronic, I would like to extend a very warm welcome to the Luncheon Symposium on Hancock II, the gold standard bioprosthetic valves. My name is Dr. Vikram. I lead training and education for the cardiovascular business for the Asia-Pacific region. And today, we are indeed very honored and privileged to have Dr. Tyrone David, who is going to deliver this lunch symposium. Dr. David was supposed to be here in person, speaking to all of you, but because of the rapidly evolving novel coronavirus situation, he could not make it. So he's currently back in Canada. It's almost 12:30 p.m. It's after midnight, so thank you for staying awake. Before we go on to the lunch symposium, I would like to introduce Dr. Tyrone David. Dr. Tyrone David is a professor of surgery at the University of Toronto and the holder of the Melanie Monk Chair of Cardiovascular Surgery at the Peter Monk Cardiac Center. Dr. David has published 351 scientific papers, 55 chapters in medical textbooks, as well as 5 surgical textbooks. He has developed numerous operative procedures to treat patients with heart valve disease, complications of myocardial infarction, and thoracic aneurysms. One of these procedures is also known as David Operation. He has been a member of the editorial board of several medical journals and is a member of numerous surgical and medical societies all over the world. He received the Order of Ontario in 1993 and the Order of Canada in 1996, the highest honor given to civilians in Canada. So without further ado, please put your hands together for Dr. Tyrone David.
Thank you very much. I'm very sorry for not being able to be there physically present. A lecture is never the same, looking at a television screen, as opposed to have me at the podium, look at your eyes and talking to you. I went as far as the airport on Tuesday, but I had a common cold and low-grade fever. And I was informed that they would not let me board the airplane because all passengers were being screened for temperature going to Asia or come from Asia because of the fear of coronavirus. I think it's an exaggeration, but however, I have to follow the rules. So my apology for not being there. Medtronic asked me to speak to you about Hancock II bioprosthesis. I first implanted this valve in 1982, believe or not. It's a very old bioprosthesis. But in spite of all new developments, nothing measures up to this bioprosthetic valve as far as durability is concerned. We published our experience from 25 years in 2010, and unfortunately, I could not show to you the results of over 4,000 prosthetic valves implanted in my hospital, followed to up to at 35 years. And the message I'll convey now is the same as we will have, hopefully, later this year on the outcomes on 4,200 patients who had valve replacement with Hancock II valve. Another reference that we published in 2014 on the same bioprosthetic valve, but only on younger patients, for your reference. Is a porcine valve. Is a whole porcine valve. It's a whole pig. And initially, the fixation process is done with no pressure. But soon after, it pressurized to a diastolic pressure to close the valve. It is highly selected. Any valve with excessive muscle bar is discarded. And then is mounted in a Del ring stent covered with a polyester fabric. My involvement, I have no financial interest in this valve whatsoever, but my involvement was that in 1980, we published a paper whereby we proposed to the industry that tissue valve should all be supraannular to be able to implant a larger valve than was done back in 1980, when all the bioprosthetic valves were intraannular. My apology for a minute. My grandson is sleeping with us. I was speaking so loud he came to my room. I had to send him back to bed. He said, "Grandpa, what's going on? Who are you talking to?" He certainly thought his grandfather is going crazy, be talking to a television. Anyhow, he's back in bed. My wife came in and took him back to bed. The boy is only 5-year-old, so he doesn't know the difference. Anyhow, we first implanted this valve in September 1982, and we have done over 4,000 implants over the past 38 years. The report, however, that I have to give as a reference is published in the Annals of Thoracic Surgery as well as the European Cardiovascular, where we had 1,134 patients. They're fairly old. Most of them were above 60. However, we had 206 patients under 60. The majority, as I said, are over 60. But that's the typical population for the aortic valve replacement in Canada, in North America. We don't have very many rheumatics. Most of our patients are bicuspid or degenerative aortic stenosis. As any cohort of aortic valve, most are men, most in sinus rhythm. And the usual associated diseases that every patient who's 60 or 7 frequently have. Nowadays, very different, but back in the 80s and 90s, most patients came to surgery because of symptoms. Now, I would say more than half of all patients who undergo aortic valve replacement are asymptomatic. They have a lesion, and once it becomes hemodynamically severe, be stenosis or insufficiency, we recommend surgery. And again, most of them had normal ventricular function. Very few with quite impaired ventricle. Most patients had aortic stenosis, and the only 1 in 5 had pure insufficiency. Half the patients had coronary artery disease, so require concomitant myocardial revascularization. And that's the pathology. As I mentioned initially, very few rheumatics. Most of them bicuspid or tricuspid calcific. Hancock II valve does not come in size 19. It starts with size 21. And I have, in my entire career, been very reluctant to implant valve size 21. I think, I believe a heart valve 21 should go in a very small patient with body surface area below 1.5. Anybody else should have a larger valve. Of course, to implant a larger valve, frequently you have to patch enlarge the aortic canals, which you do even today, one patient in 5. As it turned out, was the right thing to do back in the 80s and 90s, because all these patients now, when their bioprosthetic valve fails, they can have a TAVI, they can have a valve in valve, because most of them had the valve pretty large. There is one major drawback of the Hancock valve prosthesis. The effective orifice is very small compared to a porcine valve. At least 10 to 20% smaller for the same geometric aortic orifice. So a 21 is an effective area of 1.1 to 1.2. Therefore, you should not implant a 21 in patient with a body surface area larger than 1.6. A 23 should go to a patient with body surface area smaller than 1.75. Otherwise, you're going to have too much of a mismatch in high gradients. Now, of course, the large ones is no problem. We target hours to give a patient at least 0.8 centimeter square per meter square or body surface area. These patients were followed prospectively up to 2014. Then we had to stop for lack of money for this research. They were contacted every second year, and 96% had the echo every 2 years. So we knew what was happening to the valve. The mean follow-up was quite long, up to 27 years, mean or 12 years. And we lost only 11 patients in the whole cohort. At the time of this report, 55% of all patients had died. In other words, after a mean time of 12 years, more than half had died. 4% was operative deaths, 11 was valve-related, 13 cardiac-related, and 27 non-cardiac-related. Why they died? Well, they died because they are old, very powerful. Older you are, more likely you are to die during follow-up. Because they had a hypertension, a chronic lung disease. They were, at the time of operation, in heart failure, low ejection fraction, peripheral vascular disease, renal failure, or they had concomitant coronary artery disease. If you take a look at a Kaplan-Meier, at 20 years, there were only 34 patients at risk and a survival of only 18%. But remember, there were 67 here. If you break down by age, things are not as bad anymore. The younger than 60, 54% were alive at 20 years. 60 to 70, 22%. And older than 70, only 2%. It means if you're older than 70, your chance to make it to 90 is not very high. Like any prosthetic device, it comes associated with a constant but a small risk of endocarditis. In 1,100 patients, we had 41 episodes in 39 patients. 20 years later, 94% are free from endocarditis. Like in any patient with aortic valve disease in mean age of 67, there's a constant risk of thromboembolism. And although many of them are unrelated to the valve, we have to report as such. So at 20 years, only 77% were free from strokes or GIAs. How about failure by echo? In other words, more than mild aortic insufficiency or a gradient greater than peak systolic of 40. And that's how we define echo failure. After a mean follow-up of 12 years, there were 67 failures in 206 patients in the younger population. In a 6 to 70, 18 failures, which is less than 10%. In over 70, only 2 failures. No reoperation. But by echo, the valve was no longer okay. If you take a look at Kaplan-Meier, it looks like that. 99.7 at 5 years, 97 at 10, dropped to 86, and then 63 at 20. If you break it down by age, very different. The younger patients, 20 years later, only 1 in 3 had a normally functioning valve. I'm not saying they had a reoperation. The echo was abnormal and indicative of valve failure. Reoperation, of course, much better because you don't reoperate in all patients who have valve failure. Either the valve failure is not significant enough or the patient is too sick to have an operation. So it's 100% in people over 70, 90% in patients between 60 and 70. That's a damn good result. And unfortunately, the younger one, only 32%. So if you implant a bioprosthetic valve, anybody under 60, the patient is going to come back for a reoperation, almost guaranteed. Anybody over 60 is most unlikely they'll come back for a reoperation. The reoperation is not always due to valve failure. It was due to prosthetic valve endocarditis, paravalvular leak, and we took it out of 10 normally functioning valve because of an episode of acute aortic dissection, which is a bento, and the patient required a standing aorta replacement. We replaced the valve, and the patient required bypass, and the valve was too old, so we took it out. So at 20 years, the freedom from reoperation was 65% for all patients. Only 30% for the younger, 87% for the middle-aged patients, and 98% for the elderly. If you take these numbers and compare to all pericardial valves ever published, Professor Robin Tula from originally from Portland and then from Los Angeles, in 2010 published a paper that pericardial valves are more durable than porcine valves. Of course, I sent a letter to the editor immediately disagreeing. And as a reference, he used the old Hancock and old Carpentier bovine valve. And that's how the Perry-Mount shared in a collective series. And that's how the first porcine valve shared. If you take the same graft and plot the Hancock here, this is how the Hancock, put in this graft, look the difference. This is the porcine valve from reference that Professor Ramintula used. This is the Hancock. No comparison. This is the pericardial valve that Professor Ramintula used as reference. This is the Hancock. Much better. And if you compare to all other publications to that time, and even after 2010, nothing compares with durability with Hancock valve. This valve undoubtedly is the most durable tissue valve for aortic valve replacement. But it's very dependent on the patient's age. People under 60 are very likely to come for reoperation. Patients over 60, most unlikely. Our conclusion was that our data did not support the general belief that pericardial valves are more durable than porcine valves at any age group. The Hancock II specifically is more durable than any pericardial valve. In the mitral position, things are not as good because the pressure is higher. This valve closes at systemic pressure. In aorta, it closes at diastolic pressure. So the mechanical stress in the mitral is much greater than in the aortic. Hypertensive patients do not do very well with tissue valve in the mitral position. But we had 310 patients to study, and Dr. Borger published this data about the same time as we did. A bit younger, now half and half women, and many of them had a pacemaker or atrial fibrillation. And many patients had a previous mitral valve repair or replacement. Here again, most patients had an advanced functional class. Very few lower functional class. And rheumatics are a relatively small proportion. Ischemic and myxomatous were the main cohort. Like in the aortic valve, because of the age, approximately half had coronary artery disease, and most of them had fairly normal ventricle, although 23% had impaired ventricular function. Valve size here is not as important as in aortic position because the diastolic interval is much longer. So a 27, 29, and 31 likely is adequate for everybody. In addition to the mitral valve replacement, 43% had bypass surgery, 13 had tricuspid valve repair, 1, the tricuspid valve had to be replaced, 1 replaced the aorta, and 5% had reconstruction of the mitral annulus because of either in the endocarditis with an abscess or because of MAC, calcified mitral annulus. Much higher mortality, twice as higher, 8%. And the usual complications that most open heart surgery is associated with. The follow-up wasn't as long as the aortic valve because the sample size is much smaller, but also 99 complete with echo. And half the patients were dead. 17% of the all deaths were operative, is the 8%. 16 valve related, 39 cardiac and other causes. It's amazing how many die because of the heart, because a large proportion had ischemic mitral regurgitation. Now, Kaplan-Meier, at 15 years, survival was only 30%. Not very encouraging. And the valve-related mortality, the freedom, 86. In other words, 14% die because of complications of the bioprosthetic valve. Thromboembolism similar to the aortic valve. Patients in atrial fibrillation were on Coumadin, and warfarin reduced the risk of thromboembolism, but increased the risk of hemorrhage. And reoperation is not as good as the aortic valve. 69% are free, but 31% require reoperation. If you split by age, younger the patients, much higher reoperation than older patients. So in patients over 65, on this analysis, wasn't as bad as younger patients. In summary, the freedom from valve failure at 10 years was 86%. At 15, dropped to 66. In younger patients, 80% at 10 years, dropped to 60 at 15. The older patients, 91 and 74. Everything is relative. So compared to the aortic valve, in a mitral position, this bioprosthetic valve does not have the same results. But this is the same for every operation compared to aortic or mitral. Mitral valve has more complications. However, it is the most durable bioprosthetic valve, and certainly much more durable than pericardial valve. Although a very old valve, 38-year-old, we continue using as our primary tissue valve when the patient chooses to have a tissue valve. We, in a small aortic route, we favor pericardial valve. We think it's better because it provides better hemodynamics. But if the patient is younger, we rather enlarge the annulus and put a Hancock valve than use a pericardial, because we don't believe, we have data that it is more durable. Thank you. Any question?
Professor Sairon, I have a question.
Yes.
Why Hancock II start site at 21 in aortic position?
Because it's obstructive. Is a too small area. If you put it in a 19, the orifice is going to be only 0.9 centimeters square, which is a very small valve. To be quite honest, I'm not sure 19 valve should be implanted in any human being, except perhaps in children. Because if the valve fail one day, you should have a valving valve. And that's the current technology. We have no valving valve for 19 available today. And there'll never be, because the orifice is too small. At 21, you might be able to do a valving valve, but the residual gradient is very high. And that's the main reason why Medtronic chose not to use a 19. Be quite honest, they not made a 19 on my recommendation.
Thank you so much.
Back in 1982.
Anybody has a question?
Professor Tyrone, this is Vivek Zavli from Bangalore.
Yes.
I have a question that this porcine bioprosthesis did so well, which is glutaraldehyde treated porcine at that time. Now subsequently so many better ways of tanning and better ways of tissue preparation have come, lower profile. Do you think the newer generation porcine valves, say like Mosaic, will it outdo the Hancock outcomes?
I don't know. The data is not there yet. I would suspect because it has a better anti-calcification treatment, it would do better, particularly in younger patients, if anti-calcification works. But as you know, the scientific basis for what to do in bioprosthetic heart valve surgery is not very good. Our clinical knowledge far exceeds all the science on bioprosthetic technology. So companies come up with new things all the time and keep saying, this will be more durable. And then implant for 10, 15 years, it falls apart. I mean, I was very disappointed recently because I repair most valves as opposed to replace. Whenever I can, I try to repair. If you repair a lot of valve, we have to use a patch. We don't have a good patch material. So I began to use cardiocell. Cardiocell is pericardium without cells. It's cellulized. Experimentally, it doesn't calcify. Well, guess what? Implanted in human beings, in 5 to 6 years, turn into a sheet of calcium. And yet, experimentally, doesn't calcify. It doesn't calcify in animals, but it calcifies in humans. What I'm trying to say is, this experience can be extended to bioprosthetic technology. Yes, there are newer methodologies coming every year, but none of them have passed the test of time. So it's very likely that Mosaic is more durable than Hancock, but we don't have data yet.
Thank you.
Thank you, Professor. Hello.
Yes, I can hear okay.
You hear me? Yeah.
Yes.
Thank you,
yes.
Professor David, for this wonderful presentation, for this wonderful lecture. I have two questions for you. Grigore Tenica from Iași. I'm still waiting for you in Romania.
Yes. Well, one of these days I'll be there.
Yeah, in September, late September. So, first is if there are any treatment anti-calcification after valve implantation. What do you suggest for this patient, especially for young patient, because now, and this is a second question, what do you think about newest trend of lowest of age of implantation of biological valves to 50 years?
Let's answer the first question first. There is no evidence that we can do anything to modify calcification for our own aortic valve or bioprosthetic valve. There were some retrospective studies showing that patients have low cholesterol, non-hypertensive, non-diabetics would do better than hypercholesterolemic patients, hypertensive and diabetics. Has been disproved. Statins were thought to reduce calcification in human native aortic stenosis. All randomized trials are negative. We ran a trial for 12 years on statins and Hancock valve. Made no difference. Interesting enough, the only difference we found was patients with blood group A had much lower calcification in the valve than other blood groups. We don't know why. Likely, human beings with a group A blood may have some antigens similar to the present in porcine tissue. The second part of the question is bringing the age down to bioprosthetic valve. Everybody's doing this. And to be quite honest, if you take a look in database from Europe and database from United States, it began before the days of TAVI. TAVI hadn't been invented yet. And yet, on the late 90s and early 2000s, surgeons began to use more and more bioprosthetic valve as opposed to mechanical. I think it's a mistake. We're going to pay a price, or a patient can pay a price. If you implant a bioprosthetic valve in anybody under 60, most of them are going to live long enough to have a bioprosthetic valve failure. Then they'll be faced with the decision to, should I go for a reoperation or do a valving valve? Well, if the first bioprosthetic valve was large enough, 23 or up, you can have valving valve. But how durable is going to be? We don't know yet. Now they begin to bring the age down for TAVI. We in Canada are doing at least once a month a reoperation for failed TAVI now. Because they are bringing the age down. Well, start implanting TAVI in 50, 60, or even 70-year-old. It's not going to be as durable as an 80 or 90-year-old. So my bet is, yes, it's okay to use a bioprosthetic valve in a 40 or 50-year-old, as long as the patient understands that he or she will come back for more intervention.
Thank you.
I imagine patients don't like to take warfarin, and that's the main reason. It's not only the doctors trying to force on the patients a type of valve or other. My bet is, look at yourself or myself. I would like to take warfarin if I could avoid, and perhaps a reoperation would be less harmful, or a reintervention if it was TAVI, a valving valve. It would be less harmful than a warfarin for a lifetime. Particularly as you get older, becomes a problem to take warfarin. What do you do in your practice? Do you use mostly tissue or mechanical.
So in my practice, until a few years ago, I used mostly mechanical valves. And I would like to tell you a story. In 1996, I operated on a lady, 70 years old, and they put a mechanical valve, and she is still alive. She had pacemaker, she had breast cancer, but she is living now because in a few years, anyway, she has atrial fibrillation, and she is taking Coumadin. So in part of this patient, even in old patient who has very long expectancy of life, I put in mechanical valves. If I have a patient if I have a patient and I ask him he's 65 or 68 or 70 years old, and I ask him how your mother is doing, and he's saying, okay, she's 95, and she's okay, and my father also is 98, so I will put a mechanical valve to this patient. Otherwise,
Well, I think it's the right approach. I agree with you. People take a reoperation casually, but it's not. If you take a look at reoperation by the average surgeon, it comes with a significant mortality and morbidity. And valve is not the solution yet. If you take a look at collective large number of series of valve, they all require anticoagulation. They have to be on warfarin afterwards. Otherwise, the valve-in-valve thrombosis. The thrombosis of valve-in-valve is much higher than TAVI as a first therapy. So those patients require warfarin anyhow. Why not put a mechanical valve like you're doing when they're young and take warfarin for life? But as I said, many patients don't like to take drugs. So thank God we have an alternative for those patients.
On that same note, Professor Tyrone, I would like to ask another question, that if the patient with a mitral disease has already come in atrial fibrillation, and the patient is 65 years old, but why not put a mechanical valve? Because anyway, we have to manage the anticoagulation.
I think you should, to be quite honest.
Because
and if it's rheumatic,
yes, because
if it is
in India,
rheumatic, as you know,
yeah, where I come from, most of them are rheumatic mitrals. And secondly, they all come late from the remote areas, and so they are already in
so
AF.
large atrials.
So the chances of MACE success are not very good. So I would rather not put a bioprosthesis, because anyway
I agree entirely. Yeah. Unless, of course, if you think the lifespan will be longer than the bioprosthetic valve. If a 65 or 70-year-old has breast cancer or has coronary disease, they're not going to live 15, 20 years. So in those cases, I guess it's justifiable to put a tissue valve because you might be able to stop anticoagulation. However, rheumatics, as you know, the newer type of anticoagulation do not work very well for rheumatics. If they fibrillate, you better give warfarin. It's the only medication that is effective in atrial fibrillation with rheumatic heart valve disease. Apixaban, Pradax, all these newer drugs do not work very well for those patients. So a mechanical valve likely is a better alternative. But can you anticoagulate the patients in India? Do they take warfarin?
Yes, it's much easier today than yesterday, because the reach of
Better
clinics
healthcare.
is better, and the understanding of the
right.
patient is better.
Yeah. But that's an important thing in third world, in developing economies. The patient may not be able to afford, may not be able to do the blood tests unless there is a public healthcare system that can look after them, which many countries don't have. We're very lucky in Canada. Healthcare is entirely paid by government. There's no payment at all. medication given by the government, blood tests by the government. So Canadians are very lucky in this regard. Any more questions? Well, thank you very much. You have an afternoon of lectures and other courses, and I'm going to go to bed.
Thank you, Dr.
1:30 in the morning here.
Thank you, Dr.
Pleasure.
Tyrone David. That was
Sorry I
an
couldn't be there.
That was an
Very
amazing presentation, and we had a very interesting discussion. I know it must be almost 2 a.m. In your time zone, and I hope
1:30.
your grandson has gone to sleep. So
He sounds.
hopefully we see you in this part of the world when we do not have a virus wreaking havoc. Wish you a good night, and thank you all for coming for the lunch symposium. Thank you.
Thank you all.